Can you focus on me? All right. Hello, everyone, both joining physically and virtually. It's my pleasure to welcome Professor Rajesh Sundaresan to deliver a keynote in person. He's going to talk about a data-driven decision framework for COVID-19 response, a personal journey. So Professor Rajesh is a professor of electronics and communication and at IISc. And over the years, he has had visiting positions in various institutions, including UIUC, including at Qualcomm. He's currently also the Dean of the Division of EECS at IISc. He's a highly accomplished researcher in all areas of communication, data science, but these days he's interested in data-driven techniques for healthcare. And so I'm eagerly looking forward to his wonderful presentation. Thank you so much for joining us.
Thank you for the invitation and for being here. And I'm happy to give a talk in person. It's been a long time since I did this. So I'll speak about data-driven decision frameworks for COVID-19 response, and it's a personal journey. Mostly I'll speak about computational epidemiology tools and how an accidental epidemiologist, and that's what I was, and my collaborators got into building these tools. So let me rewind the clock back to March 2020. On the 10th of March, at the end of a seminar that I was organizing at the Robert Bosch Center for Cyber-Physical Systems at IISc, a colleague came up and asked, wasn't holding the seminar a little unsafe? Aren't you worried about the coronavirus? My immediate response was, what coronavirus? I was actually feigning ignorance. It was in the air. I had heard about the Bangalore cases. 24th February, there was an IT professional that was identified as COVID positive and had traveled to Hyderabad on a bus. And then on the 8th of March, there was a case from Dell, I think. On the 10th of March, somebody from Mindtree. And on 12th of March, a Google employee. And then the first death at Kalaburgi, okay, Gulbarga in Karnataka. That might have, or perhaps there might have been other things as well, triggered closure of all the public spaces in Karnataka with high footfall, particularly malls, universities, and colleges. And IISc was one of the entities that closed on that day, on the next day, 13th of March. So Friday, 13th of March, so that evening I got a call from one of the administrators and a collaborator. The institute closed today. All students are to go home over the next 2 to 3 days. There is some uncertainty about when to open. We have studied these mean field models for control of packet delivery and opportunistic spread in delay tolerant networks. Is there someone who does such things for diseases in the institute? Is closure needed, for example? Can we use modeling to figure out when to reopen? So this was the question that was posed. And when this question was posed, I was racking my brain as to who does these kinds of modeling of diseases and things like that. There were many, I did not know it at that time. But the next morning, I set to work, and the next morning, it was clear why social distancing was proposed and whether closure and other things were indeed needed. And I prepared a short presentation. This is actually from there. You can see the 15th of March 2020 and something at the bottom which says, do not distribute as if it is some state secret. In reality, it was that I was a little embarrassed about the simplicity of the model that I was making. And I'll come back to speak about this simplicity aspect a little later towards the end. Okay, so the model was this susceptible, infected, and recovered model, something that was familiar to many of us because we were doing this kind of modeling for delay tolerant networks. And so the kind of topic that this conference focuses on, it was something that was useful in the modeling. Now, in this SIR model, it was a fixed population model. People would interact with each other, and when they interact, if a susceptible and an infected individual would interact, then the susceptible person would become infected, some Markovian evolution, and so on. There are two parameters, the contact rate as well as the recovery rate. So don't worry about the details. It's just a story at this moment. And one can write down the Markovian dynamics associated with this, the conditional expected drift, how does the susceptible increase or decrease per unit time, how do the infected increase or decrease per unit time, recovered, and so on. You can write all of these things down. These are incremental over a delta t, and then you can normalize, you can divide by delta t, get derivatives, you can normalize by n, get population fractions, and so on. Pass to the limit as delta t and n go to infinity. This is something that's familiar to all modelers. As n goes to infinity and delta t goes to 0, you get an ODE system, which is something like this. Very simple dynamical system. Now, this simple dynamical system also has a closed form expression corresponding to the beginning of the pandemic, when the number of susceptible people is very close to 1. You can get a closed form expression, which is there at the bottom, explicit solution on the right. And this is fairly accurate at the beginning of the pandemic. So we got all of this, and then there were a bunch of curves corresponding to how China looked, how France had increasing cases. Italy was already struggling at that time, and so on. And I was trying to figure out how to fit the parameters, the contact rates, trying to read some papers to understand what the recovery rate ought to be and things like that. And the issue related to, there was a jump because the Hubei province reported a lot of cases on one particular day. How do you bring those things into account? When you're dealing with real data, there are these aspects of reporting that also came into the picture, and one must handle those. These were things that were on my mind, but some things were clear. For example, the relationship between the contact rate and the recovery rate, and how the contact rate, if it is a little smaller than the recovery rate, that's all that you need. And so you probably didn't need complete closure, you just need some sort of reduction in activity. That sort of answered the question to begin, but there were still issues related to what is the correct contact rate, how much do you reduce by, and so on. So while I was working on this and trying to figure out those things, there were others also doing this, and I came across this epidemic calculator and another link to a Python notebook, which was quite elaborate. All of these were beautifully done and in a much more elegant way with an intuitive user interface than the simple methodology that was prescribed in the slides that I had. And then I was, so what use was the tool that, or those equations that we had developed. We set it aside, but very recently, I'm able to see the, very recently, we brought it back to work, and you can actually see that this is one of the models that's working in what is called a forecast hub, about which I'll come back and speak at the end. The predictions at the very end, you can see a slight increase that's corresponding to the Omicron wave that we are seeing now. There were other events that happened. This is, remember, March 2020. I learned about the Diamond Princess cruiser and asymptomatics, and that at that time I always said asymptotics instead of asymptomatics. Nowadays I say asymptomatic instead of asymptotic as I get back to things that I'm doing. In any case, Italy was struggling in Lombardy and Veneto. France had announced closures, and my collaborator, who was supposed to visit around the 12th of March, he had cancelled the trip. And then I learned about UK's singular strategy of herd immunity. I mean, if the rest of the world will drive on the right side of the road, UK will drive on the left side of the road. So they were trying this herd immunity strategy, which I felt was, it seemed rather brave at that time. And then a flip the next day. Is it on the streaming? It's fine, I can continue? Okay. And then there was a flip on the next day. And the reason for the flip that UK made was that, there was an agent-based model that was built, and a report came out on the 16th of March from the Imperial College. This agent-based model seemed very appealing. It was kind of the thing that will appeal to modelers very much, I would say. They had an agent-based model for the entire country of UK and also the United States. Okay, so there it is. Every individual had a digital twin. There was home interaction that you could isolate. Schools, workplaces, communities, all of these could be isolated. And then you could think of non-pharmaceutical interventions on each of these entities. We could answer every question that we wanted to about reopening IISc. That was the feeling that I got when I saw this. The projections seemed somewhat unbelievable. So I requested the lead author of that paper for the code so that we could modify it for Bangalore. I was thinking more of Bangalore. UK is about 60 million, Bangalore is about 12.4 million population. I was thinking of starting out with Bangalore, for example. He himself was, the lead author himself was down with COVID-19 at that time and didn't respond. In any case, we would have had to adapt the code even if he had shared it with us, which he did later. But even if he had shared it at that time, we would have had to adapt the code for Bengaluru. So why not build it from scratch when we will have complete control over the code? And we got together a bunch of volunteers at the Cisco IISc Center for Network Intelligence. These are the names of the volunteers. Mostly they were people that were reporting to me. So when I requested them, they were kind enough to humor me. And then a few others joined later. We got to work. A few days later, I just wrote to our Cisco contact to check whether we could repurpose the resources, and he gladly allowed it. And that's how our city scale agent-based simulator was born. What does the city scale agent-based simulator do? It creates a synthetic population of agents in the region that you want to model, a city, for example, or a country in the case of the UK. And then we model the disease dynamics, model interventions that one would like to see, and simulate the spread in the synthetic population, not in the actual population, but in the synthetic population via our Markov chain, and understand how it evolves, how effective certain controls are, and so on. So here are two models that we built. I mean, it's the same model. We instantiated two of them, one for Bangalore and one for Mumbai. And here you can see that both Bangalore and Mumbai are very heterogeneous. What is color coded there is the number of people living in that small area. The larger the number, the darker the color. Mumbai has 24 wards, Bangalore has 198 wards, 12.4 million agents on roughly on each in each of the places. The BMC area is a particular administrative area which has about 12.4 million people, estimated for 2020. And you can see that there is actually quite a bit of heterogeneity. So if you use the model, which were the homogeneous SIR models, then they would not pick up this heterogeneity, whereas these agent-based models could, if you instantiate agents in exactly the proportion to the population that's here. That's exactly what we did. We went around gathering data from the census, gathering data from maps, put them all together, tried to understand what were the mobility patterns from one ward to another, added all of those into our city scale simulator and built a synthetic city, the synthetic Bangalore and the synthetic Mumbai. So these were two cities that we had. And the synthetic city had digital twins for every agent in the locality or in the city, and they would be associated with homes, they would be associated with workplaces. We also took the unemployment ratio into account in each of the wards. That data was available, and we took how far people would go also into account. So all of these were taken into account, and this was the synthetic city that we built. The synthetic city, for those that are modelers here, you can abstractly think of it as interaction spaces. So those are the, like for example, the blue one corresponds to interaction space, which is at the home. There are 4 people in 2 of the homes and 3 people in the third home. But these people are not isolated. There are children in in these homes that go to schools and they interact at the schools. And then there are children, there are parents that might go to work. If somebody is COVID positive, that person, maybe the younger one, that person spreads it at home. The younger one goes to school, may spread it to somebody else. Another kid, and then that child may come to another home, spread it there, office interaction. So you can see kind of how it spreads. There are also market areas and public transport spaces and community areas that we had modeled abstractly. It looks like a bunch of bipartite graphs where one party is common, and that's the individuals. The other parties are all interaction spaces, and there are links between them. So the individuals is sort of the link between all of these bipartite graphs, and there is epidemic that's evolving on this particular network. Okay, so with this, the agent-based model is actually something that's amenable to a lot of detailed modeling. For example, you take a workplace into account, like the Indian Institute of Science. There are departments within this. You don't have homogeneous interaction across the entire institute. There is interaction, more interaction within a department than across departments, even though there may be across department interaction. And even within the department, there might be intergroup interaction, which is lower, and intra-group interaction, which is higher. So the agent-based model can model such things. Similarly, schools, there is more interaction within a class than across classes. So all of these could be modeled, and we did that, and we built this synthetic city. The blue one, for example, is the data, and the red one corresponds to the parameters in our city scale, in the synthetic city, in synthetic Bangalore. Now you can see that the age distribution sort of matched. It matched on these parameters: age distribution, the distribution of household size, the distribution of workplaces at the bottom left, the distribution of workplace distances, commutes from one ward to another, and so on. That was also taken into account. These were data that we had gathered based on surveys. Somebody had them, and they gladly shared it with us. And then the distribution of school sizes and so on. So a synthetic city was matching reality in these parameters. Of course, there are many others where it might have been different, and one needs to quantify those things as well. In addition to building the synthetic city, you also need something about the disease biology, how it evolves within an individual, when does the individual spread, and so on. So that was coded up in this. The important things to note here is that there's an incubation period, there is pre-symptomatic, asymptomatic spread, then there are those that recover, there are those that spread with symptoms, and then there is age-dependent branching. Elderly are more susceptible, so the branching depends on the individual's age and so on. And then there is the transition from hospitalized to critical, and the unfortunate ones that pass away. All of these also depend on the age as well as the comorbidities. So where do we get data for these? So thankfully, there were some studies on early data that came from China. So age-dependent branching, there's this paper that had come out on the 9th of March, once again from the Imperial College, which estimated all of these parameters, the susceptibility for a particular age group to requiring hospitalization, to requiring critical care, and perhaps succumbing to the disease. And these are all based on data. These were early days, based on data from China. I wish we had done such studies. We still are not doing such studies as much as we would like to do them, but that's another story. What about comorbidities? So here is another study, also from data from about 1590 patients from China, and that involves people with hypertension. What's the chance that they will need ICU versus those that do not have that are not suffering from hypertension? So with this data, you can essentially create an individualized model, the agent-based model, and that's precisely what we did. And this sort of shows the kind of interactions that we were modeling. I just want to focus your attention on the rightmost side. So there's interaction at home, there's interaction in the larger neighborhood, and there's interaction with friends across the city, for example. There's interaction at school, there's interaction within a class, interaction at the workplace within an office, and interaction within a group, which is at a higher level than the typical workplace interaction. We also modeled transport, interaction at market spaces, restaurants, theaters, religious locations, events, all as a common entity. And that interaction could actually be somewhat widespread compared to the others. So the reason I put this up is to just indicate that all of these will sort of lead to a certain contact rate, a particular transition rate for an individual that is susceptible to infected. And I want to call out those spaces because then you can target those to control those areas to reduce the interaction there. Home isolation, for example, closing workplaces, and so on. Now, that's exactly the point I'm making here. So let's focus on the red. You want to understand the effect of home quarantining, how effective it is, compared to perhaps school closures and college closures. So you could go and model this. And the way you could model this is in the following way. Following identification of a symptomatic case in the household, all household members remain at home. But what that also means, which is difficult to do in an SIR model, for example, is contact rates within home will increase. And here, as one hypothesis, the contact rate may double. And community interaction with the community goes down by 75%. So if there are 4 people in the home, perhaps one of them is going to the market and picking things up. So that's a 25% interaction compared to the original, or a 75% reduction. And here's the other thing. We could model compliance as well. Not everybody is going to follow all the rules that have been laid out, not all the time anyway. And therefore, it might be good to bring those things into your model. Assume 90% compliance for this, or 70% if it is a place where either people do not follow rules willfully, or perhaps it's just impossible because of the crowd to be able to follow those rules. Okay, so when you see this, you kind of get the feeling, and I got this feeling, that ABMs, agent-based models can solve about anything. It just seemed like the right tool to answer many policy questions. We could address, for example, Bangalore's traffic. We could simulate and understand people's behavior and anticipate the problems as it would appear at the Kaveri Junction, where two U's make a straight. We could also answer Delhi's perennial dilemma by quantifying the effectiveness of the odd even strategy. So it could be used for plenty of things. So as a sort of an educational tool, we built this particular simulator. Here you can see that it's a 1 lakh city. It's a mini Bangalore, mini scale Bangalore, about 1 lakh in the population versus 1.24 crore. That's roughly about 1:100. And you can run this. It's still running. You can set up whatever are the disease parameters. If you scroll down on this website, you will be able to see several lockdown parameters that you can set, and you can see how effective certain things are, and you can see how things will evolve. It's something that we built in JavaScript. Of course, it's not scalable. So in order to build a scalable model, what we needed was people, and we decided to crowdsource talent at that time. So this was around March, early April. Building synthetic cities is not easy, and the simulator wasn't easy either. So we sought volunteers. We spoke to several people, about hundreds, and we tried to get Mumbai people to model Mumbai, Delhi people to model Delhi, Kolkata people to model Kolkata, Palakkad, etc. And we convinced some of the best CS theory people, you would be surprised, and applied probability people to join forces and work with us on this. And these were some volunteers, for example, from a company, SAP. There were some students who were eager to contribute in any way they could. They were just looking for some direction, and we tried to channelize their energies. People from TIFR, Sandeep, Piyush, Ramprasad, Prahalad, and their students. And I'm so glad they all joined, because we could turn our JavaScript code into C++ in record time. We parallelized it, we made it efficient, we made it robust to concurrency issues, which plagued the Imperial College model. And we scaled up to 12.4 million agents and 2 big cities, all within a matter of about 3 weeks or so. Now, as we were building this, it looked like things were moving a little faster than we could handle. The national lockdown came on the eve of the 24th of March. It was our attempt at a zero COVID strategy following China. And it felt really like entering a Chakravyuh. And I was hoping perhaps this kind of agent-based model might be a means by which we could guide unlock. 13th April onwards, there were some guidelines for unlock, but things were still moving too quickly, because the unlock strategies were such that they would take some time for us to model them and see how effective they would be in our simulator. And also, we were doing some strange things. We were trying to do some counterfactual simulations rather than simulating reality. We were trying, okay, what if this, what if that, and so on. We were trying to do some academic exercise on the simulator. And a colleague at IISc knocked some sense into us and asked us to model reality, so that decision makers will actually find it useful. So we changed tack at that time and tried to get the real pandemic model and tried to figure out how it could be useful to modelers. And here are two things. So the issue was we didn't know how to calibrate, and we were trying to figure out some ways to calibrate it. They were all academic exercises until we thought hard and tried to figure out a way to do it. The way to do it in retrospect was quite simple. We just had to take all the deaths in India, put them in Bangalore or put them in Mumbai, and then there was also the lockdown. But before the lockdown effect kicked in, we had to essentially gather, or we had to gather only that data where the lockdown effect did not kick in, which means we had to focus on the fatalities. The fatalities take about 20 days or so to happen. So on the average, and therefore we focused on the fatalities and brought all the deaths in India to Mumbai or to Bangalore, calibrated it, and then looked at the model and brought in the lockdowns and things like that. So if you see there, we brought in the lockdowns. They were all models, but the curve that you see is something that followed the real trend. That was not something that we had calibrated to. It came out of the model. Therefore, we were relieved to see that at least the model was tracking reality. Just to give some pointers, I think at that time, the prediction, if there were no interventions, it would have been about 20,000 deaths or so in Mumbai. That is this particular top. This is about 10,000, and this is in log scale. So just above is about 20,000 or so. think as of 4th January that we have had 16,000 official deaths in 16,384 official deaths in Mumbai. Something similar for Bangalore as well, about 16,411 deaths, whereas the prediction was a little under 20,000 or so. But of course, these are registered deaths. There have also been variants, etc., which were not modeled there. And when you bring these interventions into place, you actually break the transmission to some extent, which helps as well. Okay, so those two plots and that report that we had, I think it was on the 19th of April 2020, and we had built this in record time starting from about 18th of March, within about a month or so. It got us some connection with the policymakers, but I must say, after some uncomfortable situations, for example, we had to make press releases before archive, let alone a peer-reviewed publication, and we were simply not used to these kinds of things. In any case, we got some connection with the person at the Karnataka State Disaster Management Authority. So he called us in for a discussion, listened to us politely. He was trying to understand what our model was saying. He himself had a model, and there were two other people that had already gone and spoken to him. So there were many competing models that he had at his disposal. In any case, he listened to us politely and then posed to us several questions, which he thought that the agent-based simulator could answer. And the questions were not clear, but this is the articulated question subsequently. That led to the first of our city-scale simulation studies. So one of the unlock strategies was we'll open three places. Those are the IT and IT-enabled services areas, government offices, and then the manufacturing and the SEZs, which have access control. So let's open those things up. But when you open those up, let us consider the possibilities of 100%. 50% was the guideline, and with greater compliance. So you're opening it, but you enforce compliance, versus you keep it closed, but compliance is poorer. So it kind of, at least this question after articulation asks, can we open and then invest in more education so that people comply and so on? Or is it better to keep it closed and wait for some more time? You will still invest in education, but perhaps we can open if we invest in education. So these are the kinds of plots that you get. So it's a very heavy slide, but I'll just make you focus on a few things. So there's compliance as well, and the 90% compliance is the one on the, just focus on the curve on the left. There's 90% compliance on the left. If you lock down, that's what you have. But if you open with 90% compliance, the workplaces, 100% or 50%, the cases would rise. On this axis, this is about 400. Okay, so it's not clear on the LED screen, but that's about 400. So things would rise a little. This is early or middle of April or so, 2020. But if you didn't have good compliance, that is, if the compliance was only 70% instead of the 90% that's assumed, even if you were in lockdown, it's poorer. So invest in education. Try to get as many people to comply as possible. Get more people to try to get people to follow the rules. So this was one interesting outcome that we had. While we were doing this in Bangalore, our colleagues in TIFR were working with the Brihan Mumbai Municipal Corporation, and there they were worried about containment zones. So those were the days when for every case you would put a 100-meter containment zone. We didn't have enough information about the virus at that time, and we did stupid things like that. And we would have a containment based, which was triggered on the number of hospitalizations in that particular area. So until then you don't have containment, and then post that you start containment. Or it could be something which is a soft containment, which scales up and then eventually locks when the cases exceed a certain threshold. But they were worried about effectiveness, containment effectiveness. So you need to go get your food supplies. So 75% effective. That means only 1 out of a home of 4 is likely to go out. But Mumbai is full of chawls, and there are several places where there are a lot of people, and the effectiveness is possibly a little lower than the 75% that one might assume. So what if the effectiveness is 60%? Does do the cases explode and so on? Also, they wanted to understand, what if we open trains at 30% in September, 60% in October, and 100% in November, a phased opening, and offices opened similarly, because there's no point opening offices and not having trains, because how will people get to their offices? But you can stagger offices, use shifts to aid in social distancing precautions. And also, what if trains were operating at a slightly higher level of operation than the base level? So all of these were modeled. And you can see here the predictions for Mumbai in terms of the deaths. This is, I'll tell you the dates there. So we stopped this particular plot at around September. So you can see that the deaths are fairly well tracked, but if you look at the deaths, there was also an adjustment that happened, which accounted for the gaps that you see here. So all of those are well modeled, but this is as far as deaths is concerned up to September 2020. But if you look at the cases between Mumbai and Bangalore in our agent-based model, there was this inexplicable delay that we still haven't understood completely. The cases were essentially about 3 to 4 weeks later. So something was happening with the reporting, and these are things that you have to take into account when you're building an agent-based model, and and you're trying to interpret the results. Anyway, these were issues, but these were it was at least following the trend that we saw. There was a delay that we couldn't figure out at that time, and we couldn't figure it out because in Bangalore that was exactly it was matching better for the same code, just the parameters were different and matched to Bangalore. So that was the Mumbai. So that's what they were modeling and sharing with the Brihan Mumbai Municipal Corporation authorities. So that sort of brought us to interact with some other entities which were doing similar things. The Virginia Biocomplexity Institute, for example, has had a tradition of modeling disease, modeling epidemics. And Google was interacting with them because they had mobility data that they could share and try to understand. But of course, the mobility data, Google put those things out. Residential, this is the number of, this is the increased presence in the residential areas and so on. Google mobility reports were coming out. This was a little more detailed than that. And we teamed up with Google as well as University of Virginia to figure out perhaps what we could do to understand opening up of trains or the locals in Mumbai. And we thought, why not study a way by which we could structure interactions, and that is by cohorting. So cohorts are those that travel together, and when they travel together, they enter and leave a station together. When they do that, you structure the interactions. Already there is a structured interaction in home, workplaces, etc. Maybe further structure those interactions, a sort of bubble, a travel bubble. When you do this, not only do you change the network, but you also are able to target testing, you're able to target isolation and so on. So it can have multiple benefits. What are the benefits of each of these components? Okay, which one is the most beneficial? So that's exactly what we did. For example, we figured through the simulations, this was all the simulation study, that structuring alone is not enough. You have to test and isolate. Okay, if somebody in that cohort is positive, you have to isolate the entire cohort. That's what is beneficial. You should detect symptomatic cases at the station. If it is only 40% effective, even if it is only 40% effective, you can bring things down significantly. If it is 20%, it rises. If you don't, then it's cohorting is not effective at all if you're not able to detect them. And we also thought of coach seating assignment. So already cohorting is structuring interaction, but the cohorts themselves, today you might have cohort 1 interact with cohort 2, tomorrow the cohort 1 might interact with cohort 3. Why not structure that even further by using fixed seating? This cohort and the other cohort will take the 8-10 local from Mahalakshmi to this particular place, and they will essentially get onto this particular coach, and they'll be in that particular coach. So when you do this, you're further structuring to what extent is this effective. So we figured that when you did the simulation, this sort of additional structuring did not help. And it's really the cohorting, testing, and targeted testing and isolating that is helpful. And there were a few other things. To what extent is the disease transmission sensitive to crowding? It was very sensitive, so you have to be careful. Of course, in retrospect, it's obvious, but you can quantify this as well. Larger cohort sizes are better. And we also identified the number of quarantined. The number of quarantined didn't change much. So it was a little higher when you have the cohorting, but the reasons for which they are being quarantined is different, and it might make them unhappy. It's because somebody that they traveled with is positive, and you're therefore quarantining them, versus in the other two cases you're quarantining them because somebody that they know, a relative or a friend, is somebody who has been identified as COVID positive. And we also modeled what if people do one-off travels. So you might not go in cohorts, a certain fraction of them may not comply, and they might travel on their own. Even if 40% of the people are one-off travelers, this seemed to be helpful. So all of these were communicated with people at the central government, and Niti Aayog perhaps felt it was too bold an idea to ignore. So they called us for a meeting with railways personnel and metro officials of a few cities. There was even NAIMS doctor and many other stakeholders, and all of them highlighted the implementation aspects related to compliance and tracking logistics, which is actually it would have been a nightmare to implement this. But we had done many other strange things, so why not this one as well? The feedback was we look forward to seeing a version 2. So we actually did work on a version 2 where we thought of some better strategies where you do some gating. So if a person goes from, let us say, Dadar to Churchgate or Mahalakshmi to Churchgate, and that person is positive, then you look at how many people travel in that route or how many people are positive and travel in that route. Accordingly, you decide a certain number of people should not be allowed to enter the station. It's just a soft gating, and similarly on the Churchgate side and vice versa. So if you do this, that's what I call randomly gated, but at the source and the destination corresponding to the individuals that have been identified as positive. If you do this, the number of cases increase a little compared to the other one. So 4,000, that's also 4,000. You see that it's going a little above 4,000, but it's a strategy that's eminently doable with just a marginal increase in the number of cases. That's easier to implement than the other one. We went one more step further and we tried to just give a signal saying that there are this many cases and randomly gate across all stations. That's also not too bad. So this is our version 2, but by that time I think when you take it to the government authorities, it better be perfect the first time, otherwise you will not have traction. So the version 2 did not get buy-in. But I get asked this question all the time, but Professor Rajesh, aren't there too many parameters? Won't we be overfitting? In defense of agent-based models, these are constructed bottom-up. You take the data as is from the city census, you take the household distribution size as is, and so on. Similarly, you take the disease parameters from clinical studies, past flu cohort studies, and so on. You don't touch them, you don't modify those. The only thing that you change are the contact rates, seeding, compliance parameters, testing parameters, which are much fewer in number. And you calibrate independently on a smaller scale system and then use that in the larger scale system. So there are some inbuilt checks that are there to ensure that you don't overfit. But when we saw the testing numbers fluctuate and how case ascertainment depended way too much on the number of people that were being tested, we realized that it was a difficult task to just maintain this going forward. So here is an example where we tried to adjust the testing numbers in Bangalore. They were ramping up rapidly. This was the stage when the number of tests were about 6,000, but our simulator, when we tuned those parameters, we were either too short or too large compared to the red one, which is the actual data. It was a little difficult, and it is an art that turning these knobs to ensure that you match and also you are able to justify them is something that we still haven't figured out how to do in the later stages of the pandemic. In the beginning stage of the pandemic, it's okay, but in the later stages, there's still quite a bit of distance to go. Okay, so summary of ABMs is the following. So it's difficult to match in the later stage of the pandemic because of myriad variations. And the expectation is to match to past data for stakeholders to adopt these tools. Otherwise, there's no buy-in. And we couldn't scale to hundreds of cities and districts. This was one of the asks of the supermodel committee members. And we couldn't create an instance on demand. This was another ask for our agent-based simulator because it required careful tailoring and also a lot of data about a city. But we did create Wuhan, New York City, Cochin, Mysore, Delhi, Sweden. But it wasn't really ready for scale up, at which point of time we felt that it required more work. So maybe we should focus on some other things. So what are ABMs good for? I think they are things that we can work on and make them work well in future. They can help us with scenario A versus scenario B comparison. They can identify the right instruments and target those for intervention. And in smaller scale settings for campuses, for example, where the stochasticity is important, they are quite useful. And so we have actually built this thing called the Campus Rakshak Simulator, where we have modeled IIT Jodhpur, IIIT Hyderabad, and IISc. And it's actually part of something called the Campus Rakshak as a service, which has several things: the Go Corona Go app, which is a contact tracing app, a testing strategy, a tapestry pooling testing, and then there is something, a monitor, which gives you information about the disease in an individualized way. It's called Health Badge. And there are two other agent-based models that have been utilized. So thanks to CNI, DST, and a few others that supported us on this. So this is something that if you would like to use it in your campus, we'll be happy to talk to you. So I'll skip this in the interest of time. We built some readiness calculators, but I will not dwell on that here. Okay, so I'll now go to our interaction with the government. So colleague Shiva Athreya from the Indian Statistical Institute and I took many of our tools that we had built up to that time to the health department, Department of Health and Family Welfare Services, through our KSDMI contact. So this colleague, Shiva Athreya, was closely following the daily bulletins. Now he would, when he finds an error, he would alert them. He built contact graphs from the bulletins that were being developed. Okay, so the tools that he built was like, there were situations like this. Somebody would be declared as deceased on day N. 5 days later, the same person would be declared as recovered and discharged. These are simple things that can be fixed, but I think because of the overload in those offices, these things were not being done. And so he was building tools of that sort to ensure that the data that's being gathered is as accurate as possible. We tried our best to get Karnataka to share machine readable data. Of course, PDFs are machine readable, but they are not standardized format across states. So we tried to do that, but to this day, we have not been able to get them to share CSV files or in a particular format, or certain text files in a certain format. In any case, they said we have a different problem. And I want to highlight that problem because it's an interesting OR problem. Okay, so the OR problem is related to transferring swabs to labs. How to use the lab capacity efficiently. So see, Karnataka test cases, the number of tests that were done around 15th of September of 2020 was something like this: about 66,000 tests, roughly split equally between the RATs, rapid antigen tests, and the RT-PCR tests. All of India was doing about 11 lakh tests per day at that time. Of course, now we are doing a lot more. Now, these were the kinds of cases that we were getting. And remember that the test positivity rate is somewhat small, so you should multiply this by either 3 or 10 to get the actual number of tests that are being done, swabs that are being collected. So it's a large number. So the total, for example, for Karnataka was, you take Bangalore, roughly double that. So 3,084, roughly double that, 6,000, 7,000 or so cases. September, Karnataka had a peak October 13th in 2020. So 3,000 multiplied by 2, 6,000 multiplied by 10, 60,000 samples had to be sent to the lab. So that's a logistical question. And the way they did that was they would send it to different labs. The point to note here is at the bottom, there is something called Kidwai Memorial Institute of Oncology that was operating at 12 times its capacity. Whereas look here, Indian Institute of Science was operating at 25% capacity. So there was a huge imbalance here. And we actually participated in a sero survey. I will speak very briefly about that a little later. Those sero survey samples were special samples that had to be accorded priority processing. And these were the kind of delays that we saw. About 1/3 of the samples in the sero survey, which had priority sampling, took 4 days or more. Okay? So the capacities were not being utilized properly. Surely we can do something better. And there was a simple and an elementary solution. But I must say that we got up to the stage where we got it into the state war room, but the switch was not turned on. But I'll tell what the solution is because it's an interesting problem. So who are the key players in the allocation procedure? There are the district surveillance offices, which are collecting. There are 30 districts, one per district. Each district has a hospital. It's collecting all these swabs. The swabs are then sent. They are collected by the healthcare workers and brought to the surveillance office. These are the different kinds of tests. There are different costs for each of them. There are different labs, about 113 labs operating at that time, different capacities, etc. Some were closed because of routine maintenance, some because maybe the personnel that were operating were positive and the lab was not functioning and so on. Here are example capacities of a few labs in the hundreds mostly. So the procedure was that the DSO would enter the number of swabs collected that day, and he would do that, or he or she would do that before 7 p.m. There was a drop-down menu which mapped a primary lab for the district, and there were secondary labs shown with capacities. The DSO would make an RTS, and then the lab would essentially do a CTS or a reject. And this was asynchronous. The negotiation was asynchronous. Usually the primary lab will accept, but sometimes it wouldn't, but nevertheless you had to do this negotiation. Labs would enter their testing data in some portal, but they had too many portals in which they had to enter data, and sometimes they just wouldn't do it on time, and this affected the calculations, and there was wasted capacity. The issues are that the DSO's attention, which is to be focused on core health issues, has been taken away from that and transferred to transportation issues. Unnecessary negotiation and human intervention where it was where we could have avoided it, and there was information that was not collected effectively or used effectively, which resulted in wasted capacity, cost, or test delays. And that solution anyway that was not scalable. So I'll just quickly go to, so we built a sort of engine that would do this. The algorithm would essentially search within the district, then within 3 hours of the district, that's the second one, round 2A, and then only if you didn't find something within those 3 hours, next one, yeah, then you would use all the labs in Karnataka. So the kind of assurances that our tool could give was you could transport out of the district only if the district capacities were completely utilized, and you would transport beyond 3 hours only if every lab within the 3 hour segment was overloaded. So these were kinds of things that we tried to build. So these were the kind of transfers you can see in that picture. So it did involve transfers from Hubli to Bangalore, for example, from Udupi to Bangalore on occasions, and so on. Now we built this, tested, even integrated it into the war room, but the switch was not turned on, because that was the time when there was the peak, and we had to train all the DSO staff to be able to use this, and the focus was on something else at that particular time, and we couldn't do this. Had we done this, so this is the kind of benefits that we could have gotten. So these are the backlogs that were there on the data if we had used the algorithm, which is what we used. But had we used the other algorithms, those many colored ones there, the non-blue ones, would have been the utilization, would have been the backlogs much lower. We could have handled it quite easily. And had we done this, had we integrated this, the long delays for test results in wave 2 in April may have been much lower. For example, I know of cases where a person was COVID positive, but it took 4 days and 21 hours for that person to get a BU number, by which time the person may have recovered, thankfully, or perhaps something else might have happened. But these are things that we could have avoided. In any case, we tried our best to get it into the get it integrated into the system. We failed there, but we did try and succeed in getting a lot of people to be engaged with this. So we conducted a hackathon. If we had one solution, perhaps there are so many other smart people, they might have better solutions. Why not leverage their creative minds? So we conducted a hackathon. This was around November, December timeframe, and several teams participated. There's a solution from IIIT Hyderabad, and a solution from IIT Guwahati, and another from IISc Bangalore. And those were visualizations. There was another competition for visualization. So this was more like an attempt to get them engaged, to be more aware of the pandemic and so on. Okay, so I'll say a few words about sero surveys. This is something that, I mean, perhaps the most useful thing that we have done. We helped Karnataka with the Sentinel sero survey, which was conducted all across Karnataka. Karnataka has perhaps the most comprehensive, has done the most comprehensive sero survey amongst all the states. There were 290 centers from where samples were gathered. We leveraged the state's AIDS prevention and tuberculosis surveillance teams to conduct the tests. And when we entered, the design was somewhat ad hoc, and possibly we were invited to participate in this because we were troubling the state health department a little too much, and this might have been a way by which they could keep us occupied. In any case, so when we joined forces, it was already, there was an ad hoc design, perhaps a design by committee, which had for some only RT-PCR would be done, for some only the RAT would be done, and so on, because of protocol constraints. That made it very difficult because there would be constantly missing data that we had to handle on every line item for every individual. If you have only a partial number of tests, if you have only a partial number of tests, how do we account for perhaps the calculation of how many are positive and so on. It was a big issue, but what we did is we turned that question into a mathematical question, into an optimization problem, where we took test costs and reliabilities as constraints that we had to meet or deal with. Reliabilities is whatever, if the test is a poor test, you have to deal with that. And then we tried to minimize the errors, okay, or it's sort of the mutual information, trying to maximize the mutual information for those that are familiar with information theory, between the data that you are trying to gather, which is what fraction of the people have the disease, versus what you're gathering. Speaking a little more statistically, we try to minimize the variance of the estimations of the surveillance of the seroprevalence. Now, when you do this, you actually get a much simpler design, and this we managed to convince the state to use in the second sero survey, and that was a much simpler sero survey to analyze. In any case, there was quite a bit of variability across districts in the first round, as well as between the first round and the second round. First round was conducted in September, when there was a significant rise in cases. The second round was somewhat calmer. That was done in February, but of course it was the lull before the storm. And these were the kinds of things that we could put. So on the y-axis, on the x-axis, you have the infection fatality rate. The infection fatality rate is how many people that get the infection pass away, unfortunately. And then on this axis, we have the cases to infections ratio. The larger this is, and this is information that you get from seroprevalence because it's an unbiased estimate. So the larger this is, the more cases you are missing. And so ideally, we would like districts to be in the bottom, possibly to the right, because there's no reason to believe that the infection fatality rate is different across the different districts. Statistically, we seem to be similar across the districts, which seems to suggest that we should be in that region where Bangalore is. That's Bangalore. So we would like to be in that region. All the districts should have been in this region. What this suggests is that there are some districts which are doing well, which are detecting cases. The infection fatality rate is perhaps what it is, and we can't do any better than that. Perhaps look at clinical practices. That's about all we can do. But on this side, all these districts, they are missing significant number of cases. And if they are not seeing the same kind of deaths that are there, something's the issue there. So we should go and track those places. So we gave automated reports of this sort. Davanagere is one of the towns or the districts that I had visited. So I was monitoring that particular district. And these are the kinds of recommendations. It was a rule-based one, some expert system that we had developed to be able to say that in this district, this is what you should focus on: clinical management, as the district is seeing a higher number of COVID-19 deaths without a surge in cases. Improve clinical management. Death audits should guide efficient clinical management. Things of this sort. So these were rule-based. So we also, around September, there was this hygiene hypothesis that was floating around. This one, for those here, you will not be seeing this clearly. It's Sporocarmicas, waste collectors. So in the second sero survey, we ensured that we would track them and try to understand whether the hygiene hypothesis had any basis. Would it hold water or not? And sorry. Okay. And it's about 14.5% with some uncertainty band, which sort of was common across all of the other categories of individuals that were sampled, other strata as well, which seemed to indicate that the hygiene hypothesis, at least from this data, had no basis. Okay, so what we did well in the sero survey geographical spread, we used Sentinel sites, we leveraged them. No new infrastructure was needed. We did it twice. But it was suboptimal in the first round. We actually corrected it in the second one as well. But I think we did not get Davangere, for example, and other districts to be able to take the data and use it more effectively. We couldn't get reliable data on deaths for better IFR estimation. Okay, so how much time do I have? Maybe 2 minutes? Okay. So we also took this data and tried to come up with vaccination prioritization. I'll possibly skip this. So just to indicate, we would ideally like all of those districts to be at the same point. They should all be clustered. They should all be moving, this dose 1% and dose 2%. They should all be moving in lockstep to the right towards 100% and 100%. But that's not happening. there's quite a bit of heterogeneity. I mean, the intention is to keep them all in lockstep, but the capacity to absorb at these districts is somewhat limited, which says that or suggests that some action is needed to ensure that more people are vaccinated in those places. It's a little better now. This was in September 2021. It's a little better now, but we still have work to do. Okay, so I want to just end with some things, some things that we can learn from other countries or should learn from other countries. I think we have an over-reliance on one model, and we must get away from that. Here is an example that the CDC follows in the USA, where there are 30 plus models, and the CDC is the one that that sort of hosts this, and then reports that our ensemble of models provides these things and so on. I think when you do that, maybe one model might not be right all the time, and perhaps some other model which was not doing well initially might catch it. So it's important to do that. And towards this, we have built a forecast hub, which I hope all of you, if you're modelers, you will contribute to. And we stopped pushing our model and embraced half a dozen. And here are the things that we have for Karnataka. For every district, I think these things are there. It's a short-term prediction, but there are also some longer-term predictions that that we have. So I encourage you to tell modelers that you know to provide predictions to us. We also built an early warning system triggered by some interactions with the state when the state asked us about is there a rise in March 2021. We did not see the rise happen, and so we saw that the rise was something similar to what happened in Sankranti. So it's not yet it's within the noise, so perhaps we should wait a little longer. And that later on we were proved wrong. The rise kept on going. That suggested that we had to have an early warning system. We have built an early warning system, an RT calculator, which sort of says that these are the districts. I'll just read out the districts here. This is from 7th of December. Kodagu, Mandya, Vijaypur are seeing some rising cases. Watch out in Belgaum, Bangalore Urban, Dakshina Kannada, and so on. And then those are states that are in a comfortable position. We've also been doing something related, COVID-19india.org, many of you know it. Hats off to those volunteers. They have been collecting data, standardizing it, putting it in a place where modelers can use it. Even government officers could use it. Making it all available in an easy to digest form. But they stopped operations on November 1st, and we have continued their operations. And you can go to incovid19.org and take a look at that. The look and feel of the web page is also similar. We have since November 1st about 500,000 page views, about 58,000 users, and they're engaged with this with an average engagement time of about 3.5 minutes or so. There are also Omicron projections that you can see when you go to that website, which seems to suggest that the peak might be, unless some action is taken, might be around late January, or depending on the parameters, there is some uncertainty about to what extent people are susceptible to Omicron. And if you look at the South Africa one there, that suggests that we should follow the black one. And so that might be in the third week of January or so. Some concluding remarks, I'll stop. I think you have seen a glimpses, I've given you a glimpse of various tools. We hope we'll be able to make these mature going forward. I think there is an impending mental illness pandemic, and we have to prepare for that. We should have possibly kept our schools open with better preparations, better safety preparations there. But now we are going to deal with primary school literacy issues, as well as secondary school students not being able to adjust. So these are going to be some social adjustment problems later. It has been a struggle to get data. When all districts' data is centrally available, I've always wondered, why did the COVID-19india.org people spend so much energy when it could have all been pulled from one single ICMR website, or in data.gov.in, for example. Data.gov.in is data.gov.in, and what we need is data.gov.out. The PSA's office indicated that data will be available on April 30th. We could have done many interesting things with that data. Somehow we have not been able to get ICMR or NCTC to release this data. There's been a struggle to share data, the data that we have, with other modelers and other analysts. That's the Sero survey data. We have anonymized it, but still the government is somehow not very comfortable sharing it. Just like judicial independence, election commission's independence, accounting entities independence, we must have data independence as well. So that's one remark that I would like to make. I was very uncomfortable with the way science communication was happening. The press release first, social media next, med-archive later, peer review last. I think something's the issue with that kind of science communication and science communication by Twitter. Maybe that's the way of the future. Perhaps we have to get used to it, but I was uncomfortable with that. We had a rich set of insights and district-wise recommendations and actions, but the response to it from the districts was slow. I think this is something that we can work on and correct, and we should do that. We have optimal designs now. We have the idea of Sentinel sites that we used in Karnataka. We could use this to conduct frequent sero surveys and standardize sampling frames and so on. Last slide. The stored sera that we have could be very useful in understanding our immunity against new variants, Omicron. We've not been able to convince researchers to do this in the lab, while elsewhere such studies have been done, particularly in the UK. This is because of some sort of separation between service-oriented research and basic research in our academic institutes. Service-oriented research, the former is an excellent resource of relevant research problems for the latter, and the latter can benefit from the former, and former can benefit from the latter as well. But I think it has not happened in many of, I have failed to get people to come. So in a society which scorns excellence in plumbing, because plumbing is a humble activity, and tolerates shoddiness in philosophy because it's an exalted activity, will have neither good plumbing nor good philosophy. Neither its pipes nor its theories will hold water. Thank you.
So much, Rajesh, for the wonderful keynote and the personal experience, as well as the humongous impact that you've made in helping India, like guiding India in this pandemic and saving as many lives as we can. So we have time only for a couple of questions. Okay, so people who raise their hands first get an advantage.
Thanks, Rajesh, for a fantastic presentation. I had two questions. One was, how does this model that you have compared with the sutra, which is like popularly talked about and comes in newspapers and all over thing? Or can you combine the two and do better, etc.? Okay, that is one. I'll come to the next one. Maybe you can answer that.
Okay, so the sutra model is also an SEIR model. They have some additional states. So we also have that model. The sutra model is scalable. So we recognize that right in the beginning. So ours was also one of the things that we were hoping we could scale up. And that's why we went and canvassed, advocated people to build models for their own cities. I think if we do that, there's a lot of tuning that needs to be done, but it might come to some level of being able to model what kind of interventions we should use in each of those places. That's the purpose of the agent-based model. But we do have, similar to Sutra models, some other models. The last one I said, Omicron, etc., that's related to that. So there are some assumptions that the Sutra model makes, some other assumptions that we make. For example, Sutra model assumes that certain parameters are to be fitted, whereas we use the sero survey data, which is real hard data. But we make some other assumptions related to the incubation period and so on, which come from papers for us, but they fit those. So I think there are positives and negatives to both approaches. I think I would propose having all of these models in an ensemble and viewing all of them together. We have tried to communicate this, and I hope maybe better sense will prevail going forward.
I thought ISC and IIT Kanpur, at least that communication should be easier to create an ensemble of two. I mean, not
ensemble of two. We have an ensemble of about 6 now. We have invited the IIT Kanpur and the Sutra model people to give it to be put there. But I think they have their own portal, etc.
The other sort of, this is more of a technical side. See, most of these models that I see are very deterministic in nature. Now, I mean, in a sense, can't one use stochastic models or something like, something like Markov random field model has been used for nearest neighbor interactions and various kind of modeling of interactions. A variation on that, wouldn't that serve some purpose here?
So I think you're correct in that the city that has been instantiated, etc., or even if you take the compartmental models across districts, there are interactions which are sort of static. Can you have those interactions run? There is randomness at the level of individual interactions, but the interaction at the district level, what is the mobility that goes from here to there? Those are not stochastic. So you're right, and I think we could enhance that model. when you bring in that stochasticity, you also have to bring in that variance as an additional parameter. How to understand the parameter sensitivity, etc., are all things that one needs to address. We could do that. I think there's a lot more to be done, where these tools become more mature, and these are things that we rely on. And I hope more of you will take computational epidemiology and will be building these tools. Thanks.
Will, thanks.
Thanks,
Will.
Rajesh, for an absolutely wonderful talk. I mean, so intense your studies. Quick question. So, could you throw a highlight on the learnings from the other global models? Because, when the pandemic started in Europe, I remember Italy was really in a very bad shape. Europe, US. Any learnings from the models there, or the approach that they had, and any comparison with those models? Any highlight on that?
Yeah, so all of these models, like for example, when you fit parameters for disease evolution in India, you're not doing India in isolation. Yeah, I mean, there are unique Indian circumstances. The networks that we have here is vastly different from there. But you're trying to capture, like for example, let's take the example of Omicron versus Delta. What is the transmissibility increase? So you're using models, you're actually trying some methodology that you have, or you're borrowing methodology from elsewhere. You're trying how that fits there. And there are some statics, some invariants. Those invariants you try to capture, and then you try to understand how things are evolving in India. But there are some specifics as well. But there are, like the Omicron to Delta, possibly. That's an assumption. But you have to make some assumptions, otherwise there's nothing that you can do to predict. So you use that data and the methodologies in that way. The Sutra model is, or any other model, a CIR model, these are the standard models that people use. One or two assumptions here or there might be a little different. So the models are reasonably standardized. The agent-based model also is something that's reasonably standard. What interactions you bring in, etc., are the ones that might differ. So I think there is global, I would say, a common understanding of what models work and what we should be using. So we have been using that, yeah.
Yeah, thank you so much, Raji, for the question. Thank you, Rajesh. I know there are more questions from the audience and more questions virtually as well, but we are like 4 minutes for the next program, and I know many of you want to walk upstairs and need some time. So thank you so much, Rajesh, once again for the wonderful keynote. I know you're here physically in person, but to be consistent with all our virtual colleagues, we are going to give you a virtual memento, an Amazon gift card that should find you in the email. So thank you so much for joining us once again and giving us this wonderful talk.
Thank you.
All right, next we have two exciting technical program sessions upstairs in the Sigma rooms. Please proceed there on security and learning, as well as keynotes by Arunesh and Sinha and Srinivas Narayanan. Thank you.